So with this section, we are going to cover the treatment of diabetes, and our goals of treatment are choosing day-to-day prevent hyperglycemia and the effects of hyperglycemia, which can alter patients' metabolism, wound healing, eyesight, overall health, including infection over the course. So hyperglycemia management day-to-day is very important. Major abnormalities that we see in patients when the sugar is very, very high, out of control, ketoacidosis, which can result in hospitalization and can be fatal. So we'll talk a little bit about ketoacidosis prevention and treatment. That should be rare. So the dietary goals are controlling weight and how the diet can affect hyperglycemia. We are considering what the patient eats because that can affect postprandial hyperglycemia, but also the management of their medication. That could be the administration of insulin. So we're trying to prevent postprandial hyperglycemia. At the same time, we want to prevent hypoglycemia. Patients are hypoglycemic, are symptomatic from hypoglycemia as well. And we want to watch or observe to make sure patients have normal cholesterol and triglyceride levels because of its overall effect on the disease and cardiovascular long-term effects. So we can summarize that by saying that normalization of blood glucose levels is the goal. The way that we manage that is to monitor blood sugars before meals and at bedtime. There are times when postprandial checks are done, but in patients stable with a routine dosage, it should be before meals. And any patients that are pre-diabetic, or you might hear patients refer to it as borderline diabetic, we want to prevent diabetes from developing. Ideally, we want to prevent having to start medications for tighter control. And in patients that are requiring an oral hypoglycemic, we prefer not to have to progress to insulin. And we talked a little bit about how by instituting some good habits, we can reverse the progression of diabetes early on. So in terms of our physical assessment of these patients, we want to get a sense of when are they having their hyperglycemic and hypoglycemic episodes? When are they ill? Are they typically stressed? Have vascular changes already begun? Small vessel disease, peripheral cardiovascular changes, neuropathy, which can be very painful, and is weight management an issue for the patient? A good assessment of long-term observation is hemoglobin A1C. As we talked about the other day, it is more than a snapshot of the blood sugar level, which we see at an office visit. It gives us an idea of the patient's control over months as opposed to days. The other area where nursing involvement is important is nutrition, education, and maintenance. The psychosocial assessment, and that can include familial support. What other medications does the patient have to take? It's not uncommon for diabetics to have comorbidities, which require other medications. And in terms of reducing symptoms, weight loss, activity and exercise is important. And if the lifestyle is sedentary, then what can we do to change that? And we want to have reasonable goals. So an individual who's morbidly obese is going to have a different regimen than someone who is healthier and can start walking or treadmill. What other medical problems do they have? Do they have chronic knee pain? Do they have chronic back pain, joint stiffness? All of these will come into your assessment for determining what you're going to recommend for that patient. The idea is to start slow and make it enjoyable. Depending on the patient's needs, patients may need intensive therapy from the outset. In general, diabetes requires a good deal of education. For patients who are not medical, they may not have a medical background. So even self-monitoring of blood sugar is new to them. Nutrition management is typically new. It can be cumbersome for individuals who are on the go. It can be challenging to find healthy foods that are also convenient. Exercise requires incorporating that time into their schedule. If they require insulin, do they require 3 or more insulin injections per day? Do they qualify for an insulin pump? Are they interested in an insulin pump and all that entails? The other aspect of managing patients with diabetes, blood pressure control, monitoring lipids and maintaining cholesterol, triglycerides, HDLs and LDLs, which may require an additional medication. Maintenance of weight, BMI of 25, and that could involve weight loss. It may be maintenance, but it may also be weight loss. And teaching patients how to recognize early signs and symptoms of hyperglycemia or hyperglycemia. In some patients, in borderline or pre-diabetics, diet alone may suffice. It may reverse the progression of the disease. So diet in those patients may be used alone. These patients may not require medication at this point. And so we will start out with a diet, which may include a list of items that they can eat, or typically items that they would like to avoid. Largely that's concentrated carbohydrates, but we want to find a diet that the patient can enjoy, but also is allows you to manage their diabetes. But we want long-term adherence to the diet. So we want to be careful about the recommendations that we make because we want these patients to remain compliant over the long term. In general, caloric intake of 1,500 to 2,000 is reasonable, which is a typical diet, but some patients eat more than 1,500 to 2,000 calories per day. And that can be particularly tricky if you're eating on the go, if you're eating fast foods. These calories add up very quickly. 45 to 65% of carbs in terms of your overall diet each day, 10 to 30% proteins, and 20% fats. Just a good plan if the patient can stick to this. And there may be a program for weight loss in patients who are well above the recommended BMI. So that adds another challenge beyond just maintenance of one diet. Now you're changing the diet in order to encourage weight loss. You may not have to recommend bypass surgery in patients who are willing to lose weight. And we don't necessarily need rapid weight loss. We need sustained weight loss. So gradually reducing the patient's calories, changing the diet, incorporating some exercise, oftentimes will result in a slow weight loss of 1 to 2 pounds. And that may suffice to get the patient where he needs to be. In patients at the extreme ends of management, then you might consider more aggressive approaches to weight loss. And as we would imagine, a diet in growing children, pregnancy, and older adults is going to be a little bit different because their needs are different. So we have to support their needs, but still maintain a diet which is healthy. And in some patients, this may also include weight loss. So sometimes our children have to be put on a diet that allows for them to be within the normal percentile range for their age group. And that may mean starting a diet and starting an exercise program. And oftentimes, if a patient becomes sick, then there is education that the patient will need regarding what to do when they get sick. Illness increases insulin needs, and it may require closer monitoring, so they have to be aware of that. And that can be from infections such as upper respiratory infections, which are quite common, gastrointestinal problems, stomach flu, quote unquote, stomach virus, diarrhea, nausea, vomiting. All of these things can affect insulin needs. In terms of activity and exercise, we've talked a